So we're going to focus on most of the drugs that you see used in the surgery realm, not specifically, because again, usually with surgery, you're thinking more like cutting into something, like you're manipulating something. It's a lot more kind of like physical action. Like here, I want to talk about the medications that kind of help to facilitate that and make it possible. And we've covered some of these meds before because we've talked about some sedatives. However, these are going to come back up in the context of surgery, and we're going to use them a little bit differently, right? So anyway, talk about the ether bunny, which I always thought was very cute. My dad was a CRNA for a good long time. I guess still technically he's a CRNA, but he was doing it back when like male nurses were still kind of like a new kind of novel sort of thing. So he's been doing it for a while, but he always had there's a Far Side comic of the ether bunny. We had a t-shirt for him like that. So he's kind of a big nerd like I am. But anyway, I always thought it was a very cute picture. Anyway, so we're talking about anesthesia. What is anesthesia? Numbing, loss of sensation. That's a very good point there. Yeah, right. These are all kind of components of what we're talking about with anesthesia, and what we're going to talk about mainly here is trying to get a balanced anesthesia, right? Because I can give you drugs. The way my dad always described it is like when you're putting someone down for surgery, you're trying to get them as close as possible to practically being dead, so you can cut them up and do whatever you need to do, replace a heart, replace a liver, whatever you need to do, and then bring them back out of it. Getting them down is the easy part, and getting them back out of it's the hard part, right? You always have that moment of fear when you're like, oh gosh, did I just kill somebody? Maybe not. Hopefully we're not going to do that, but we'll see how we can do it with some of our medications here. And so how do I induce a general anesthesia on a patient? Just clonk them over the head. That could be one way to do it. IV medications are going to be very useful. What else can I use? Gas. Yeah, gas, right? So again, or do you have to go to the bathroom? Or? I'm just kidding. He said gas. I was joking. I didn't know if you're announcing it. I'm just kidding. Yes, you're going to use I'm a little punchy today. My toddler decided to stay up till 11 o'clock last night, and then I was on call, and I was getting calls like 4 or 5 o'clock in the morning. So anyway, so I may be a little off today. But yeah, so we're talking about inhalational and IV medications are going to be kind of the mainstay of therapy. We're going to see there's a few other ways you can do this, especially like when you're doing things like in the pre-op sort of setting. We'll find there's some role for oral medication, intranasal medications starting to become a much more big deal nowadays, especially when IV access can be hard to come by. And so there's it kind of runs the gamut from where you're doing kind of like very basic sort of outpatient sort of procedures all the way up to like general anesthesia, like I need to cut into somebody to do something, right? So a couple of definitions here. Again, obviously inhalational anesthesia is going to be when you're inhaling gases typically in order to induce an anesthesia, right? Because we know that the lungs are very vascular. We know they tend to be a very good spot for certain types of drugs to be absorbed. And then eventually where do they need to get to have their effect? To the brain, right? So again, they are going to partition very quickly, and we know the blood that goes from the lungs heads to where? Left side of the heart, and then up to the brain, right? So again, just basic cardiovascular anatomy there. So again, it's very quick, and again, very similar to how drugs like illicit substances that you inhale, things like crack cocaine, they work very, very quickly because they go from the lungs to the heart right to the head, right? So this is another thing we can use to try to enhance the medications, use lower doses and things like that, and have a very fast onset for these drugs. So anyway, we're going to talk about something called the mean alveolar anesthetic concentration, or the MAC. And so basically, and again, this is a different MAC than what we saw with HIV. You might say this is the return of the MAC, if you will. But basically, it's going to be the alveolar concentration that an anesthetic has to be at, present in the alveoli to make, basically, to prevent a standard response, right? So response to pain is usually one of the big things we're going to be looking for there. This painful stimulus in 50% of patients. Now, when you put someone down for anesthesia, do you want 50% of those patients to feel anything and then 50% of patients to not feel stuff? No, typically, and this goes like, we're talking about like effective dose 50 and things like that back all the way in pharmacokinetics. You're usually shooting for much higher than that, but it serves as kind of a useful comparison between different agents, right? So I can compare agents with different MACs, and I know they're all kind of getting to the same point, so I can compare apples to apples and say which one's more potent, which one's less potent, etc. So we'll go into more detail on that in a little bit. Obviously, analgesia is what? Yep, so again, relief of pain, and then general anesthesia is kind of the state of unconsciousness. And typically, what do we need to do for the patient when they're under general anesthesia? Yeah, usually they're going to be intubated because we're going to have to breathe for them. So a big thing you're going to see with a lot of these medications, especially depending on the dose, loss of respiratory drive is going to be a big thing, right? So again, from a respiratory standpoint, that's where we need to really support these patients when they're under general anesthesia. And then we need to be able to get them to a point where they can start to breathe again on their own and bring them out of that, right? So we're going to look at some drugs that are very good for, sometimes keeping the respiratory drive intact for a while. Do you remember any drugs we talked about, like with RSI? It was good for that. Kept the respiratory drive. Ketamine, like Special K, right? So then that was a good drug they like to use for kids because, again, when we're using it to, induce sort of a dissociative anesthesia and reduce a fracture, the kids are basically not going to, you don't have to worry as much about them losing their respiratory drive, and so it's not going to be as dangerous from that standpoint. That's good because for a quick, simple procedure like that, we're not intubating the patient, right? We just need them to have a moderate level of sedation and analgesia so that we can do the procedure we need to do very quickly, and then they can come back out of it. Versus if they're going into surgery, having full general anesthesia, that's typically a much more involved and kind of labored process there. Anyway, yeah, so under general anesthesia, typically you're losing, you're going to have analgesia, you're going to have amnesia associated with that, skeletal muscle relaxation, because again, you want your patients tensing up when you're trying to cut into them, and then loss of all reflexes typically, right? Okay, so again, anesthesia is that physiologic state induced by general anesthetics, and so you're going to find that the degree to which these different agents can induce anesthesia can be dependent on the drug itself. Some drugs are pretty wimpy at inducing anesthesia. Some of them are very potent. A lot of it may depend on the dose that you're administering. So again, I can give you, a moderate dose of lorazepam, which is what type of drug? Benzodiazepine give you a moderate dose of that IV, and that causes some nice anxiolysis. It causes you to be kind of nice. You have some amnesia associated with that, but it's not going to knock you out. However, if I keep ramping that dose up, I can get to a point where I can induce general anesthesia. It may not be the best drug for that. However, again, all depends on the dose you're using, and the clinical situation can be important here, right? Whether we're doing a quick procedure in the ER, trying to get the patient in and out, or versus if we're going to be admitting to the hospital after surgery, it's more involved, more a lot more intensive. Anyway. So typically when we're inducing amnesia for these patients, there's kind of two varieties of amnesia we'll talk about. What are the two varieties?
Retro and antero?
Yeah, there's retrograde and the anterograde. Retrograde being what? Yeah, if we're going to forget about stuff that already happened, versus anterograde meaning it's going to be, yeah, stuff from a specific point onward. So for instance, if I give you a dose of Ativan, benzodiazepine, you may get this anterograde amnesia that occurs where you're going to remember whatever injury ended you up in the ER. And again, I always go back to the ER setting because that's what I know. But typically you're going to have, memory of, say, falling or breaking your arm. However, once you get that Ativan, you may forget a lot of what happened. And again, it can be on a spectrum there where you may be a little hazy, you may remember certain details. However, you won't have full memory of what the events transpired after that. That can be very useful. However, is amnesia equal to analgesia? No, I can induce amnesia in a patient, but they can still feel a decent amount of pain, right? And vice versa. Just because I'm causing analgesia does not mean I'm causing amnesia, right? So if I give you an ibuprofen for pain that you're experiencing, you may get analgesia, but you're probably going to remember all the events that transpired after you received that ibuprofen, right? Unless you get some really weird ibuprofen I don't know about, but it's typically what happens. Some other benefits of getting these drugs that are useful for amnesia, and again, we're going to talk a lot about GABA here because, again, a lot of this stuff goes back to GABA, and we'll talk about opioid receptors and whatnot. But typically, you're going to be having some inhibition of sensory and autonomic reflexes, which can be useful during surgery, and then also you're going to have some skeletal muscle relaxation. So you have a lot of anxiolysis, you're going to have amnesia, you're going to have this kind of relaxation of the patient. That can be very useful to kind of getting them prepped up for surgery or for any procedure. So for instance, if I'm trying to reduce, say, a femur fracture in the ER, do I want those muscles to be nice and tensed up? No, I want them to be pretty loose. And so by giving them something that can help to limit that, by giving them a muscle relaxant that has a lot of these other properties, you're going to loosen them up and be able to, kind of manipulate that bone into the space you need it to, and then good to go, right? So anyway, sedation that we're going to talk about, this is being a decrease in activity, alertness, arousal, and again, that's going to be on sort of a spectrum, right? You can have someone who's very lightly sedated who may awake if I call out their name. So for some of you guys may undergo a light sedation during my talk, especially 8 o'clock in the morning. However, some of you may enter more of a moderate sedation where maybe painful stimuli, maybe need to come knock you on the head and that'll wake you up, right? Things like that. It's all going to be on a gradation, and usually you're going to find that wherever you're working, they'll have different definitions of this is a light sedation or this is a moderate sedation, this is heavy sedation, this is anesthesia. And so again, it all runs along the spectrum. We'll talk about those states here in just a few minutes. Right. So anyway, amnesia not equal to analgesia. Typically, we're going to be giving medications, either one medication that does both. So I mentioned ketamine being a really good example of an amnestic that also provides analgesia. However, in a lot of cases, we have to give two agents to provide one of each. Right. So for instance, if I'm giving, if I have a patient who's intubated, I need to keep them sedated on that ventilator, right? Because no one wants to be unsedated on a vent. Because what do they typically do if that's the case? They're going to start to fight it, right? Having a big plastic tube down your throat is not super comfortable. Patients like to fight that. So by giving them something like an opioid, which provides what? What do you think? Mostly analgesia, right? So again, provide an opioid, something like fentanyl provides a good amount of analgesia, and then by giving something like a benzodiazepine, which provides some amnesia, that way you can have a patient who's nice and relaxed and is not going to be fighting you, and you'll have a balanced sort of sedation that occurs there, right? So very frequently when you have someone who's intubated, you're giving them a IV continuous infusion of fentanyl and say midazolam or Versed, right? So you have an opioid plus a benzodiazepine, that's a very nice sedation combination there, right? Some drugs will do both, however, a lot of cases you may have to give two. So, mentioned that balanced anesthesia, we like to try to get benefit out of using pharmacokinetic parameters of our drugs and using different pharmacodynamics. So you can use things that have kind of complementary mechanisms. So for instance, by giving something like an opioid, which acts on what type of receptor? Opioid receptors, and then using a benzo that acts on helps the GABA work better, but it works on the benzodiazepine receptors. Those can work in synergy, right? They can get more activity at both of those together than either one by themselves. It wouldn't make sense to use morphine and fentanyl together at the same time, right? Because they're both acting on the same receptors. You don't get any additional bang for your buck there. So typically, we're going to be using synergy between different combinations of different mechanisms of drugs. We're going to be using drugs that have different pharmacokinetic profiles to allow us to basically be able to sedate the patient when we need them sedated, and when they don't need to be sedated, we can wake them up relatively quickly, right? Again, that's why after you go to surgery, where do you normally end up? In the PACU, which PACU stands for? Post-anesthesia care. It's just basically made to make sure patients are waking up from their anesthesia and they're ready to go, whether they're leaving or they're going to the inpatient side, whatever it happens to be. So again, that's really important to make sure we can kind of wake them back up and get them to a point where they are kind of functional on their own. So ideally, a good anesthetic is going to induce, a nice, smooth, rapid loss of consciousness. It's going to allow for a very prompt recovery once we discontinue giving the medication. And then we have a wide margin of safety, so meaning, a wide therapeutic index where even if we gave too much of a drug, it's not going to cause any really deleterious effects here. And then devoid of adverse effects. Now, how many drugs do you think we have that fit all those 4 points? 0, right? So nothing's going to be perfect here, but we can try to get close, right? So we'll talk about some different techniques we can do for that. Okay, so again, and one of these things you're going to find is that typically we like to use short-acting medications that can be given via a continuous infusion or continuous administration. So that way, because again, how long does something take to get to steady state? 4 to 5 half-lives, right? So I use something that's very short-acting and get to steady state very quickly, and then when I take it away, guess what? It clears out the body very quickly as well. So typically we're going to be shooting for short-acting medications that can be given via continuous infusion or continuous administration through gases and things like that. So we'll look at some examples in just a little bit. Okay, so again, our choices are going to be pretty varied, and so again, depending on the situation you're working in, you're going to find that in the ER setting, you get very used to a certain suite of drugs you're going to use pretty consistently. So for instance, if you do a lot of intubations, you're going to get used to a certain set of drugs. So for instance, what do you use for intubations most commonly? Rocuronium, or what's another paralytic you can use? Succinylcholine, and then what else are we using in combination with that? Etomidate is a very good one. Versed, ketamine, propofol. So you kind of get used to what you're going to be working with. So it depends on where you're working at and what type of environment you're in. For minor procedures, if we have somebody who's coming in, they're getting like a laceration repaired or something like that, you may not need really high dose, heavy duty medications. They need to be given either inhalationally or intravenously. We can get away with something like an oral product, right? An oral sedative. We can give them some oral midazolam, and that may be enough to kind of induce a nice anxiolysis. They're not going to be freaking out when we're trying to repair that laceration. You can also use things like local anesthetics. Anyone know any examples of local anesthetics? Lidocaine is a very common one. Anyone know any other examples? Yeah, bupivacaine is a big one. Ropivacaine. We'll talk about those, the canes, a little bit later. Just know that those are going to be useful for kind of localized anesthesia, but not causing really systemic effects. We'll see there's some problems with those when they get systemic. But for more major procedures, this is where we're going to see things like preoperative benzodiazepines, right? Because again, before you go to surgery, what are you likely feeling? pretty anxious, right? So again, we're going to give them some preoperative benzos because that helps to provide anxiolysis. They're going to be giving intravenous anesthetics. These are going to what we term induction agents because they're going to be very rapidly able to knock a patient down and get them unconscious essentially. And then we'll use a combination of either IV anesthetics or we'll use inhaled anesthetics. And so for instance, like, I get to deal with this. I was dealing with this all day yesterday, in fact. From the pharmacy standpoint, we're dealing with the OR all day, all morning long, for the most part when they're most busy. And we'll find that, okay, for this type of procedure, they're going to use these type of anesthetics, and for this type of procedure, they go for this. So for an example, we have like really heavy duty spinal surgeries, right? So again, anyone familiar with ortho, the spinal surgeries, they take a long time, they tend to be pretty bloody, and they are very intensive. Those patients need some really heavy duty anesthesia. So they may be getting gases, they're being administered, they're also getting things like remifentanil. We'll talk about some of the fentanyl cousins in a little bit, but have I mentioned those before? Fentanyl's brothers and sisters, like Remy, Sue, and Al, right? So anyway, so those get used in surgery a lot of cases. However, if we're doing a simple, say, tonsillectomy, adenoidectomy, that might be a lot lighter sedation you may need. You may not need as high, as kind of heavy duty of drugs in order to facilitate that procedure, right? So again, it's all going to depend on what type of surgery you're doing. If you work with a general surgery kind of group versus an ortho group, you'll get used and comfortable with those drugs there. So anywho, so we'll talk about the different types, and mainly we're going to find inhalational and intravenous are going to be our main varieties we're using here. Again, oral is mainly going to be used for much kind of low impact sort of procedures or preoperatively to get someone ready for surgery potentially. Now, with our inhaled anesthetics, we're going to find that these will be aerosolized, and they're going to be inspired at the same time you're providing oxygen for the patient, because again, a lot of times they are going to be intubated during this situation. And then some of the more common ones you're going to run into are going to be things like Isoflurane, Desflurane, and Sevoflurane. Very common ones. And they also have another one called nitrous oxide. Anyone familiar with nitrous oxide? What's another name for nitrous oxide? Laughing gas, right? So we'll talk about that a little bit later. That's going to be used a lot more for kind of pretty light procedures or to get someone ready for more kind of heavy duty drugs. But things like Isoflurane, Desflurane, those are able to provide a nice continuous sort of general anesthesia. We'll talk about those more in detail in a minute here. And then for intravenous anesthetics, we have kind of a nice cornucopia of different pharmacotherapeutic options here. We have things like barbiturates, what's an example of that? Yeah, phenobar is one we think about quite frequently. However, we're going to find there's some other ones we use here. Benzodiazepines are very, very common used in the surgery realm. Find that propofol is very useful. Remember how propofol looks? White, like it looks like it's in milk, right? It's in that lipid emulsion. Ketamine is used quite frequently, and then opioid analgesics. And then we may have some miscellaneous drugs. Again, typically they're used by themselves or in combination. And again, when you're getting a patient ready for surgery, what else might you be giving that is not really providing anesthesia or analgesia? We want to get them ready for either the intubation or kind of keep the muscles from tensing up on you. Paralytic, yeah. So paralytics are going to be another important factor here. We've already discussed those, but we'll kind of talk about how they're getting used in combination here. But you remember, when you're paralyzing a patient, you need to provide some sort of analgesia and sedation, right? Otherwise, if you have a patient who's paralyzed without any of that, guess what? They may not be able to respond to all the pain they're feeling. However, they are still going to experience it, right? Just because they can't tense up doesn't mean they're not experiencing it. So we mentioned what other paralytics we're using. We mentioned rocuronium, we mentioned succinylcholine. Is there any other ones we use? Vecuronium is a common one. Anyone can say the other one starts with a C. I'll be very impressed. There's cisatracurium or Nimbex is another common one we may use, especially up on the ICUs. But and you remember how we reversed any of those agents? Yeah, so neostigmine is good for, not for succinylcholine. We don't really have anything we use commonly for succinylcholine. However, for rocuronium, vecuronium, we can use some of that neostigmine. Remember how that drug worked? Yeah, it's an acetylcholinesterase inhibitor, right? And so by increasing the amount of acetylcholine available, we can kick those paralytics off the receptors and reestablish kind of normal neuromuscular function. Those are quite frequently used in the recovery of a patient, especially like getting them ready to go into the PACU and whatnot. Anyway, so again, combination of different drugs are going to be used for most of these patients. So again, we'd like to take advantage of using different drugs and different routes in order to kind of maximize our efficiency here. So for instance, we'll use inhalational therapy for more maintenance of anesthesia. So once they're already kind of down, we've already intubated them, gotten them ready, we can continue that sedation by using an inhalational anesthetic, something like Desflurane. Use intravenously typically as an induction agent, so I give them like a big dose of propofol or a big dose of say fentanyl to kind of knock them down to get that level of consciousness down pretty low, and then I can intubate them and then start the inhalational anesthetics to kind of keep them going. And then potentially when it's also nice, so we can use kind of local blocks and spinal blocks, epidurals, things like that for more kind of localized control of pain. So where do you think about these being used most commonly? Like an epidural potentially. Yeah, pregnancy, right? So again, typically you want to keep mom awake for that process there, but if you can just number from a specific portion down, that can be very beneficial, right? So again, and also by giving things directly into the spinal column, that also limits the dose you're having to give. So for instance, usually for epidurals, especially like in pregnancy, we're given a combination of a local anesthetic, usually like something like ropivacaine plus fentanyl. And I can give a very low dose of that being infused continuously into the epidural space, and that provides good anesthesia, but only from like basically from the waist down essentially. And you can kind of change that based on where the drug's being infused to. So anyway, that can be useful because again, that's going to help to limit the total amount of opioids that patients end up having to receive. We use this a lot for like, say for instance, like orthopedic procedures. If we can provide local anesthetics just into the site wherever the actual pain is actually occurring and deaden those nerves, and that's going to be beneficial because they won't have to receive as many systemic opioids. We'll talk about anesthetics a little bit later though. Okay, so there's 4 sort of stages for anesthesia here, and so there's kind of the initial stage of analgesia, there's a stage of excitement, there's finally the stage of surgical anesthesia, typically where you want our patients to be residing, and then there's medullary depression. We don't want to necessarily get that far, but again, it's one of those, you want to run the full spectrum here, at least learn about those. So typically in the stage of analgesia, we're going to have a patient will experience analgesia, but typically without any amnesia. So think about getting like say an oral dose of morphine, an intranasal dose of fentanyl, something like that. You're going to find that you typically will have some analgesia, but the patient will still remember what's going on. All depends on the dose though, because as you start to ramp that up even further, or maybe get repeated doses, you will start to see amnesia can start to take effect here. But again, the analgesia effect will be more pronounced as well as you increase the dose there. The stage of excitement, this is not a stage we want our patients to reside in, and you can find this a lot. Sometimes we'll induce this with certain agents and causing what we call a paradoxical reaction. So have you ever heard of like giving a kid Benadryl and they get super wired, right? Or giving a kid like a benzo and they get super crazy, they're bouncing off the walls. You may experience that in your work someday, where typically you think Benadryl, what's the main effect you're going to see with that? You're going to be pretty drowsy, right? However, some kids, when they get it, depending on the dose, they may find they actually get super excitable. They tend to enter this sort of stage of excitement that can happen here. And again, it all depends on the dose. And this is usually sort of a transitory stage here. Typically what you find is that even though the patient is amnestic, they may appear to be sort of delirious, they may be vocalizing things. However, they're not quite all there, essentially, when they're in this state. You're also going to find the respiratory rate tends to be pretty irregular, both in volume and rate. In that first stage of analgesia, typically the respiratory rate is going to be totally intact during those cases there. However, it tends to be more irregular here once you start to get this stage 2. Also, vomiting can be another pretty common side effect from a lot of these agents, sedative agents. And so, for instance, like ketamine has a pretty high incidence of vomiting. So what might I want to pre-treat with? Yeah, Zofrane is a very common drug. Again, not a lot of contraindications to it, but we pre-treat a lot of patients with Zofrane to make sure they're not going to vomit after getting something like ketamine. So we try to limit this. So basically we try to kind of, if we're going to have to induce general anesthesia, we want to blow past this as best we can and go straight to stage 3, because that's going to get our patient ready for surgery. However, for instance, depending on the situation, if I'm just repairing a laceration, do I need to get past stage 1? Probably not in a lot of cases, right? That's probably going to be good for most patients. But again, depends on the situation. Once you start to get into the end of stage 2, you kind of get reestablishment of normal breathing, or at least a regular breathing. And then stage 3 is where you're going to have either normal respiration is going to start to come back to a point here, but there's going to be kind of 4 subdivisions of the stage 3, and you're going to get kind of progressively more respiratory depressed as you go along here. And so again, you have complete cessation of spontaneous breathing, they develop apnea, and again, this is why we have to breathe for them and intubate these patients. And then finally, this 4th stage here, this is kind of the deepest stage of anesthesia that can occur here. And this is where you can start to see issues with, like, say, vasomotor center of the medulla is being depressed here. So again, you might find their blood pressure is starting to be difficult to regulate. So this is another kind of key point that a lot of the anesthesiologists or CRNAs or whoever are working with, is they're regulating things like, okay, well, and get their blood pressure back up. And another big thing you're going to find with a lot of these agents we're using for sedation, what do they do to the blood pressure? Typically tend to decrease. So like propofol tends to decrease blood pressure pretty significantly. Ketamine, on the other hand, though, and there's always exceptions, ketamine tends to increase it, if anything, right? So again, there's always going to be some exceptions to the rule. And again, without circulatory and respiratory support, death is going to ensue in this case. We don't want to really reside here in stage 4, but this is why it's so important that constant monitoring is being done for these patients, right? So again, usually if you ever walk into like an OR, you're going to find the anesthesiologist typically at the head of the bed, or the CRNA, or I guess there's even anesthesia assistants now. I guess familiar with anesthesia assistants? They're kind of, I always thought, I learned just about them recently in the past year or so. I guess they're sort of like the PA equivalent to like a nurse practitioner. So they, a few states are recognizing them now, but they're starting, Florida's one of them, and so you may start to see those providers being part of the anesthesia team. Anywho, so those providers can be at the head of the bed. They're monitoring the patient. They're looking at respiratory rate. They're looking at blood pressure, looking at heart rate continuously. What else might they be monitoring on those from a respiratory standpoint? Yeah, entitled CO2 is another big thing they might be monitoring for as well. It's becoming more and more common because again, that's telling us just how are we getting them to blow off enough CO2? Do I need to change my vent settings, things like that? But that's what they're being monitoring for, because they need to make sure that if they need to adjust their doses of medications, maybe they need to give a little more analgesia. Patients starting to move, maybe they need to decrease the gases because the pressure's starting to go down. Lots of different things like that they're monitoring for. Make sure they don't really enter the stage and kind of stay there. And you start to see there's different, sort of physical exam findings you're going to see here. Like the pupils are going to be reacting differently at these different stages here. From my standpoint, we really worry about the respiratory drive, especially in the emergency department setting, because again, our goal is to get them sedated enough to do whatever procedure we need to do, and then have them come back out of it. We don't necessarily want them to lose their respiratory drive, because then at that point we have to intubate the patient. We don't want to do that in the ER unless we absolutely have to. However, and certainly in surgery, you're going to be going far beyond that and typically residing somewhere in these kind of one of these 4 stages of analgesia here. Okay, just another table kind of showing you different behaviors here. Typically, with stage 1, they may be a little disoriented because, again, you've given them usually a sedative or an analgesic agent where they're kind of not quite with it. That stage 2, we don't like to really stay there because, again, if they're trying to fight us as we're doing a procedure, it's not very beneficial to our purposes there. But then when you get to stage 3, that's kind of where you're hitting the nice point there. Notice the respiratory drive is going to become more and more depressed here, where eventually they become apneic to a certain point. Okay. So typically they're inhaled anesthetics. These are the first group we're going to talk about here. They're going to be delivering these gases obviously through the ventilator circuit to be able to provide this anesthesia. So either they can be delivered through the ET tube, or you may find for especially things like nitrous oxide may be given via face mask, especially if they're doing like more kind of light sedations there. Typically what you're going to find is that the concentration of the agent is going to be in a mixture of gases, right? Because typically what are we breathing in kind of all the time? Oxygen. What's in even higher concentrations than that? Yeah, nitrogen is the main component of the gas that we're breathing. So you're breathing in these normal gases, but now we're adding in this component, the inhaled anesthetic. And so everything has a partial pressure associated with it. So by increasing that partial pressure, you're increasing the concentration of the drug that the patient's going to be inhaling there, right? Because again, do we want to give them 100%, say, Desflurane? No, because if they're getting 100% that, they're getting 0% oxygen, and we typically want our patients to get oxygen. It's a good supplement for your patients to have on board at all times, right? You may say you're addicted to oxygen. That's probably true, right? Most people would probably die without it pretty quickly. Anyway, so we're going to also look to see that it's enough that we're giving the gases in the inspired, gases that we're giving to the patient. However, they need to be able to partition out of that gas into, through the alveoli to the bloodstream, and then where do they need to go from there? To the brain. So they got to go partition out of that blood into the brain to have their full effects, right? So if the gas does not do that, it's not really going to do us any good at that point, right? So for instance, we're giving like inhaled antibiotics like tobramycin, that doesn't really get systemically absorbed to any appreciable amount because it doesn't have the ability to really cross over, which is a good thing for our patients, right? Especially like CF patients and whatnot. However, in this case, we want them to be able to partition over to the blood very quickly and then partition out to the brain very quickly as well. And so we're going to be looking at that solubility. Typically, we're going to find that the lower that solubility is, the kind of the faster the onset's going to be versus the more soluble it is, the more likely to stay in that blood and not really partition out to the brain. So again, the rate is going to be depending on, or the rate in which you can cause that analgesia and that sedation is going to be depending on the solubility properties of the drug itself, the concentration in the inspired air, right? So as I increase the concentration, more of it is going to be absorbed. Because again, what's the kind of the process that's driving getting that gas into the blood? Is passive diffusion, right? So again, the more I give, the more I cause that concentration gradient to change, or to be the bigger that variance there, the more likely I am to have that gas partition over, right? So again, I can always increase my dose of gas in the inspired air, the concentration, and that will increase the partition of the air. Also going to depend on the volume of pulmonary ventilation. Obviously, the bigger the tidal volume, the bigger the amount of gas they're going to be breathing in. Pulmonary blood flow can be important here. So who might you imagine have kind of impaired pulmonary blood flow? I like to think like pulmonary hypertension is one I always like to think about, right? So in some cases you may find that may actually impair diffusion there. And then looking at a partial pressure gradient between arterial and mixed venous gas concentrations. So the higher concentration is in the blood, the more likely, less likely it is for the stuff to go from the alveoli into the blood. Yes, ma'am.
When you were talking about the drug solubility and the onset, so it would be faster the more lipid soluble, right?
So you're going to find that the more soluble it is in the blood, because we don't necessarily talk, they all have to be lipid soluble. That's the only way they're really going to get past the blood-brain barrier into the CNS, right? You're going to find that the more soluble it is in the blood, the more it's going to want to stay there, and that's not really where we need it to work. We need to partition over into the actual gray matter and actually affect those GABA receptors and whatnot, as we'll see with the mechanism here in a second. So it's really going to be more of this kind of blood solubility we're going to talk about rather than specifically lipid or versus lipophilicity versus hydrophilicity. Yeah, so kind of change the paradigm just a little bit there. Anyway, so these are the things that we can potentially be changing in order to cause bigger effect from the gases we're instilling in our patient. So, and just to give you an idea, if you think about nitrous oxide, like typically, what sort of state does that induce in a patient? When you think about it, think about laughing gas. I always think about the movie Black Sheep with Chris Farley and David Spade. Anyone familiar with that movie? I know I'm aging myself out a little bit, but go back and watch that. It's actually pretty funny. But they're basically riding in a police car that has nitrous oxide in it, and the tank gets broken open. And how do they start acting? Anyone know? They're acting pretty goofy. Things are sounding a lot funnier than they normally are, and I'll tell you a funny nitrous oxide story with me in a little bit. But it does not really induce a really deep sort of anesthesia because of the solubility of it. You're going to find that it really doesn't really partition in the brain as well as something like halothane or something like methoxyflurane. So due to that solubility, you can find that the characteristics of the drugs change pretty significantly. So you're never going to find someone who's on the table having, an open GI procedure or something like that, getting something like nitrous oxide. It's just not that good of an agent. It's kind of wimpy in regards to inducing anesthesia. However, if I'm getting a very light procedure done, if I'm having like a tooth extraction or something, like, nitrous oxide may be perfect because it provides a nice light level sedation without really knocking it down things like respiratory drive or knocking down, blood pressure, heart rate, things like that. So we'll look at those kind of differences there in just a little bit. So anyway, typically these are working through the GABA-A channels, right? So they're going to be helping GABA to work better, and so they're going to be allowing more chloride to flow through. That allows the cells to become hyperpolarized. They're less likely to fire off action potentials, and so that's how we're basically going to be getting our main sedation there. So very similar to what you see with things like barbiturates or things like alcohol or things like propofol. They're all enhancing GABA to work a little bit better there. So. So that's the main mechanism we're going to be dealing with, and again, they're going to be very similar to a lot of the other sedatives we'll talk about. It's just that this is a novel approach that we can administer this inhalationally rather than having to give it IV. So typically they're going to be combined with an IV agent to provide this balanced sedation here. So the common ones we're going to run into are going to be things like nitrous oxide. Some of the older agents are going to be things like Halothane and Enflurane, and then we'll have things like Isoflurane, Sevoflurane, and Desflurane. These are some of the three common ones I see very frequently used for general surgery essentially. Notice ether is not on this list anymore. Know any problems with ether? It was super flammable, so there was cases like fire starting in ORs, not good, right? So again, there's an old school picture you'll find where there's kind of an ether line where they'd have to put like electrical plugs so high up onto the wall because any of those electric sparks from plugging something in or unplugging it could cause potential those gases to ignite. And ether, based on its density, would only rise so far in the room essentially, because again, there's always going to be passive gases that are getting in the room there. Anyway, so ether's not used, but that was really kind of the old school, kind of prototypical anesthetic inhalational agent we've always thought about. Anyone ever seen the movie Cider House Rules? That was one of the doctor in that movie was ether addict. Basically, he was always inhaling that stuff for anesthetic purposes. Anyway, another good movie you guys should go see. Black Sheep, for different purposes, and Cider House Rules. Anyway, so looking at the potency of these agents, we're comparing these mean alveolar concentrations here to kind of give an idea of like how much do we need to give to get 50% of patients to not respond to a painful stimulant, right? And so by looking at this, typically we're going to be giving higher than doses than this, right? But it serves as a useful kind of comparison when looking at these different agents here. Typically we're shooting for, say, like 1.3 times that MAC, and that usually is going to get about 95% of our patients covered and get them to a point where they're not going to respond to painful stimuli, right? You know how they test this stuff? Because obviously a lot of drugs undergo animal testing, right? And so you know how they would kind of come up with the pain tolerance for a lot of these animals? It's not that barbaric. It's not like they're chopping anything off, but basically they would have like they'd give like mice and rats and things like that, and they had their tail like on a certain sensor, and they would heat it up, and so basically whenever the tail or the rat moved its tail, that's when would have a response to a painful stimuli. And so the longer, the higher they could increase the heat there, the pain stimuli, the more sedate, more I can't think of a word, analgesialized, but that's not really a word. How much analgesia the rat was experiencing, but that's the way they used to do it, at least back in the day. Anyway, so typically patients who are going to have a decreased MAC are going to have a much more sensitive sort of effect from these drugs. They're going to be things like the elderly. People who tend to be hypothermic tend to be a little bit more sensitive to these drugs as well. But really going to find that there's no effect really on, it should be effect, not affect, on sex. So again, men and women typically get the same concentration of gases here. Height, weight really does not influences so much. So you're typically going to find that you're not dosing these drugs in the typical sense like a mg per kilo or mics per kilo sort of dosing. Typically going to be just based on the concentration of air that you're going to be giving to the patient there, right? Now, patients who may have an increased MAC or require more gas in order to induce the same amount of analgesia. I mean, patients who are maybe pregnant, those who have like alcohol abuse. Why do you think alcohol abuse would be an issue? Not liver. It goes back to the pharmacodynamics of the drugs. Where does ethanol work in the brain? Ethanol is typically sort of as a stimulatory agent, usually a sedative agent, right? So it's working with GABA receptors. So if those patients have down-regulated GABA because they're constantly getting hammered on by ethanol, guess what? They're going to have down-regulated GABA receptors that are going to be affected by these inhaled anesthetics just the same. So they tend to require more in order to, so again, similar, you could say someone who's, on benzodiazepines chronically may have a higher MAC there. So again, chronic use of centrally acting drugs like that, barbiturates would be another one, right? So any of those things could potentially increase your MAC. So if you notice a patient's not really responding the way you expect them to, it could have one of these conditions that are making their MAC higher than what you would normally think. So, and just to give you an idea, looking at the MAC fraction here, so normally you're going to be shooting, at lower concentrations, you're going to get some degree of amnesia here, but if you want to get things like, unconsciousness, you're going to need a higher MAC fraction here, but to get full immobility, to really kind of get full depression and keep that patient from moving when you cut into them, you're going to be shooting a little bit higher than that 50% mark. You're typically, 1.3 times higher than that for most patients where they're going to kind of reside there. Okay, so looking at their effects on the body, so there's going to be some cardiovascular effects. This is going to be a little bit more variable depending on which agent we're looking at. So some agents are going to be good for decreasing blood pressure, some are going to be better for increasing blood pressure. We'll look at those examples in a second here. But certainly from a respiratory standpoint, they all tend to have respiratory depressant effects, right? So they're all going to be depressing that respiratory drive. You can also actually find some decreased mucociliary function as well. So you may need to worry about things like, kind of gunk in the lungs not really being transported effectively. So suction might be more important in those cases. But typically you're going to find from the cerebrovascular standpoint, the metabolic rate's going to go down, which makes sense because we're kind of slowing everything down in those instances. And typically, things like blood flow to the, various organs like the kidneys and the liver tend to slow down as well to some degree. So the first one we'll talk about here is going to be halothane, or Fluothane is the brand name here. Again, a very potent anesthetic agent. Mainly going to be working on those GABA A receptors that I mentioned. That's going to be the same throughout all these here. Tend to have a pretty more of a medium kind of onset and recovery, which is fine. We like usually the quicker the recovery we can have, the better for these. And you'll see halothane is not used quite as often as some of the other ones, but we kind of use it here for historical purposes. And you're going to find it kind of lacks a lot of analgesic potency, right? So again, you may get a very good sort of amnestic sort of effect, a very good sedative effect. May not be great from an analgesic sort of standpoint. So you may need to add something on board that can help with that. So using things like Thiopental or like a barbiturate, using things like some other agents like muscle relaxants may be able to help with that to some degree. Also, it's a kind of a pleasant odor. You don't want your patient to have to inhale something that kind of smells really bad. That may kind of inhibit things a little bit, but pleasant odor can be useful here. And then basically how these patients eliminate the gas, well, it's just going to partition out of the brain back into the blood, and that can be eliminated through the pulmonary system, no problem. There's another one called Enflurane. It tends to be less potent than halothane, so I needed this would have a higher MAC. It had to give a higher amount of drug in the inspired air in order to get the same effect here. Again, kind of medium onset and recovery there. That's going to have a more rapid onset, so I may not need necessarily the same amount of, say, like, induction agents on board in order to get the same amount of, kind of quick anesthesia there. And the other benefit here is just kind of awakening is a lot faster than halothane. So again, we're shooting for something that's going to be able to keep the patient under sedation during the surgery, and then they wake up pretty quickly, so that way they can go to the PACU and be ready to go from that standpoint. Other side effects you're going to find here, respiratory depression. One of the things you may see, especially with these hydrocarbons, because their basic chemical structure of these hydrocarbons, especially if there's any fluorinated hydrocarbons, they tend to be likely to cause arrhythmias in some cases. You have to be careful with that. And actually, if you think about something like, you ever heard of like kids like huffing, like say like air conditioning units, the freon off of that, or like from refrigerators. I guess you didn't hang out with those kind of crowds. It's probably a good thing, right? But yeah, they would basically abuse these the freon specifically for these sorts of purposes, because they're basically chemically the same sort of drugs. They would inhale that, and they'd actually get a very sort of similar sort of sedative effect there, but also likely to cause arrhythmias due to the hydrocarbons, or the fluorinated hydrocarbons there. Anyway, anyone know other big danger of inhaling freon? A lot of thermal damage. So you can find that gas as it expels, it gets very, very cold. You guys ever use like canned air like for dusting computers and things like that and spray it on yourself? It gets really chilly. They do that basically to themselves, and so you can have like frostbite laying down in the respiratory tract. So not good. So again, another reason, don't do drugs. They're bad. Anyway, so again, with this drug, you may find that there's some hypotension. You may find some EEG changes due to things like seizure activity. So especially if you have the patient who have been seizing, this can maybe help inhibit that to some degree, because again, it's helping GABA to work better. And then be careful with the hepatic and renal dysfunction. This tends to be a little bit worsened, because again, we're kind of slowing blood flow to those organs anyway, at least for the short period while they're on these drugs. All right, now the three we use more frequently. The first one here is going to be Isoflurane. And the only reason why I remember this drug so well is because of the brand name Forane. This used to be back when we had the internet for the first time, back when we had like a 56K modem. I wasn't that old to where we had like 26K modem, but I had a 56K modem. It was the new hotness at the time. My dad's internet password was Forane, so he's kind of an anesthesia nerd. But anywho, he's changed his password since then, so you can't hack into his stuff. Anywho. But Isoflurane is a really good muscle relaxant. Has a pretty medium onset recovery rate, which is good. And this kind of came along and replaced Halothane and Enflurane, mainly due to the fact it had really rapid induction, which is good, because we want our patients, you want to spend 20, 30, 40 minutes trying to get our patient under and ready to go. Like, you want to get them ready to go immediately when the surgeon's ready to do their procedure. And also, awakening was a lot faster, so you can get them into the PACU, get them recovered, and then get them wherever they're going to be going, right? Because again, if you have a patient stuck in the OR suite, guess what? There's not as fewer people you can get in there to do procedures, and so turnover time is a very important thing in the surgery realm. So anyway, other things you're going to find here is nice because it has really kind of low post-anesthetic sort of organ toxicity, so it can be very beneficial, especially if patients have pre-existing organ dysfunction, and also does not induce arrhythmias, so good for like high-risk cardiac patients. Not going to see any arrhythmias associated with that. Again, just watch out for things like respiratory depression, which we're already kind of planning for when we're doing sedation like this, and you can see some increased cardiac output, so maybe you see some tachycardia with that, and hypotension, so kind of common things you would see with Isoflurane. I'll show you some tables to kind of compare the drugs here in just a little bit. Another one called Desflurane. This one you may see used for more like outpatient procedures, maybe used in like some emergent conditions if you need to induce general anesthesia very quickly. We had a case not too recent where we had to actually do ECMO. You guys familiar with ECMO? I probably mentioned it before. It's an extracorporeal membrane oxygenation, where basically we do heart and lung bypass for patients usually seen with like cardiac anesthesia or cardiac surgery, like cardiothoracic surgery. We had to do ECMO on a kid in the ER, and this is something where I had to do an inhaled anesthetic very quickly on this patient. So I think Desflurane was the one they ended up using there for that patient. Anyway, not good for induction from the standpoint, but that's why we give IV agents, right? So I may give something like, say, propofol to get the patient knocked down, unconscious, and then I can administer this continuously to kind of keep them sedate. And then the recovery is super rapid. So this is the more important thing we want to focus on, is that rapid recovery. About 5 minutes or so, then they're kind of breathing back on their own again. They're trying to wake up a little bit, send them over to the PACU. They can kind of get recovered, and they can go wherever they're going, right? In this case, you may find some myocardial depression. So you may find cardiac output may actually take a hit there from this standpoint. May have some issues of coronary and cerebral artery dilation. May not be a bad thing for most patients. However, maybe they are already experiencing something like cerebral edema that can actually worsen that potentially. And then laryngospasm can be another issue. Anyone know what laryngospasm is? Yeah, it tends out. What's the problem with that? Yeah, they're not going to be able to breathe very well, right? So that's one of the concerns we have. And we have what we call laryngospasm kits that we have available. At least we do that over at Nemours, where basically it contains usually a sedative agent, usually a paralytic. So if I give a paralytic, I can loosen up that larynx again and allow for easier oxygenation. So again, that's always a concern we have with these agents. You want to be careful of that, be aware of it. It's rare that it occurs, but it's still a possibility. So you have to be prepared for it whenever it does happen. All right, and then we have Sevoflurane or Ultrane. This is going to have very rapid onset and recovery. Again, used very frequently for general surgery. In some cases, you may see some bradyarrhythmias. So again, cardiac output may take a hit here, some hypotension. And actually, in some cases, some patients may get tachyarrhythmias, but more often than not, you'll see the bradycardia associated with that. But again, pretty rapid onset and recovery. So the three I see used most frequently, at least for general surgery, is going to be the Isoflurane, the Sevoflurane, the Desflurane. The other two, again, have been largely kind of been supplanted by these three, but it's good to know for historical context. Okay, so let's go ahead and see. You guys want to do a break now? Well, I'll talk about nitrous oxide and we'll do a break. Sorry to get your hopes up there for a second. Anyway, so there's laughing gas, right? Nitrous oxide. This is not the same as nitric oxide. Anyone know the difference between the two? Nitric oxide is used as a basically as a pulmonary sort of vasodilator. We'll use that for patients with like really significant pulmonary hypertension to try to loosen up those vessels to allow for better oxygenation. Nitrous oxide is what we use for sedation. Okay, generally pretty light sedation for the most part. So typically it's going to be given for more kind of minor procedures, like dental procedures is a big one. Usually as a supplement to more potent anesthetics, you may get this first before you get something more kind of heavy duty. It's kind of get the patient kind of prepped for these things. Not a complete anesthetic. It's not going to get the job done by itself because I'd have to give so much of this that basically the patient would be oxygenated at that point. So it's no good from that standpoint. And not good as a single agent. So usually you're going to be giving something else in addition to this. However, it's good to kind of keep the nice light sedation for however long you're doing your procedure for. And then again, it's going to be expired through expired air. So my funny nitrous oxide story, at least I think it's funny. But anyway, I think it kind of set the stage for a lot of the other developments in my life, I think. Anywho, so I had a lot of dental procedures as a child. I had to have a lot of teeth extracted. And I remember for one of, not because they were like breaking down and all grody and stuff, they just were not coming out on their own. So I was having my wisdom teeth taken out. And I remember I got hooked up in the nitrous oxide. I was probably like 11 or 12 or so. So I wasn't really sure what was going on, but I knew it was laughing gas I was getting. And so anyway, so I was getting it for a while and kind of sitting there just chilling. And then, the dentist came in with their assistants, and they wanted to find out if I was ready or not for the procedure. And so they said, okay, well, usually I like to tell a joke and then see how the patient responds, and I'll know whether or not they're ready. And so they said, okay, well, Panda walked into a bar, sat down, had a nice meal, and then when the waiter came to give him his check, he took out a gun, shot the waiter, and then left. And one of the patrons at the bar was saying, like, what the heck happened there? And he said, well, the bartender says, you should look up Panda in the dictionary. He looked up Panda in the dictionary and says, eats, shoots, leaves. And I thought that was so hilarious. I was just about to fall out of the chair. I was laughing so hard. And they said, yep, drug's working. You're ready to go. Right. So sometimes that can be a useful kind of predictor to see how well they're responding to it. Anyway, I thought it was funny. I didn't say you guys would find it funny. So there are some side effects of nitrous oxide. This is actually one of those things where you always have to be careful with the abuse of a lot of these substances. So I mentioned in that movie, the doctor was like an ether addict, right? So again, he's abusing ether quite frequently. Anesthesia is one of those kind of high risk sort of groups that tend to be more likely to see like diversion and abuse of these medications. When I say diversion, what do you think I mean? Taking it for themselves, essentially, right? So again, no one is completely immune to the risk for diversion, right? So again, addiction is a big problem here in the U.S. However, anesthesia tends to be more the ones that are likely to see that because, again, they have the most access to these medications. And so we actually see some chronic effects from nitrous oxide abuse. However, this is not something that's like super rampant. But some side effects you may end up finding is things like hypotension. Can be a thing. It's usually pretty mild for the most part. The other thing you might have to be careful of is it can expand volume of gas in certain air cavities. So maybe the nitrous oxide maybe partitions over into these different cavities. Oxygen gets released, and then you may see some distension there. So you can end up seeing the bowel start to become more distended. You can actually have ruptures in the pulmonary cyst. Tympanic membranes have been ruptured before, so it's something that doesn't happen frequently, but you at least want to be aware of that. Pneumothorax has happened before, so just be careful with that. And there's also high incidence of nausea, vomiting. So this is definitely when you want to pre-treat with like some Zofran or something to make sure that you kind of avoid that. And then typically, as far as contraindications go, we're going to recommend pregnant patients avoid this, immunocompromised patients, and then patients with pernicious anemia. This tends to actually cause B12 deficiency if used chronically. So if they already have that, you don't want to necessarily try to make that any worse. So that's one of those things to be aware of. Okay. So here's just some tables to kind of compare the different agents together. So for instance, you don't have to remember these points individually, but it's good to look kind of for certain trends and kind of see some of the comparisons between these agents. So for instance, like nitrous oxide, if you're comparing the MAC versus these other agents, what do you notice here? It's way higher, right? So I'd have to use a much higher concentration of that to get 50% of my patients to not respond to a painful stimuli to a point where they're probably not having any oxygen being delivered to them. So that's no good, right? So I can't really use that for a general anesthetic. However, these more potent agents, things like Sevoflurane, Isoflurane, Desflurane, tend to have much lower MACs, and so I have to give less gas into the inspired air in order for the patient to develop that anesthesia. So that's usually a good thing. And just note here that nitrous oxide good for kind of light sedation, but never going to be used as a general anesthetic as opposed to these other three. Okay. And then here you can notice some of the cardiovascular effects, just for comparison's sake. Things like kind of know like just general facts here. I'm not going to ask you specifically, the cardiovascular effects of Desflurane versus Halothane. I'm not going to get that granular with it because I don't think it's going to be that important for you guys to necessarily memorize that. However, know that changes in cardiac output are going to be likely to occur. Know that changes in blood pressure can happen here, and just be aware of that as a fact, right? Typically, for the most part, all of these are going to cause decreases in mean arterial pressure, right? So you're going to see some degree of hypotension associated with these. That's to be expected, especially with the other agents we're going to be having on board of these guys as well. But some of them are going to be doing things like increasing heart rate. Some of them are going to be decreasing heart rate. It just depends on the agent you're dealing with. If you were in, like, say, a CRNA program, I would be more kind of tough on knowing these points. However, for your purposes, at least be just familiar with the drug. This is what we're kind of shooting for here. Okay. Now, some risks you're going to see associated with these: hepatotoxicity, nephrotoxicity. Some that can be more seen in patients who already have kind of pre-existing organ dysfunction. However, malignant hyperthermia is the other big one. What was the other big drug we talked about causing this? Yeah, succinylcholine, and then your inhaled anesthetic. So nitrous oxide, I don't know that it's ever been linked to that. There might be some case reports. However, Desflurane, Isoflurane, Sevoflurane, definitely know that's a potential risk. Now, who's going to be at risk for developing a malignant hyperthermia? Not necessarily. That was more of an issue with like the potassium increases you see with like succinylcholine. This is going to be patients who have it's a genetic condition basically where they have an altered ryanodine receptor. Whereas ryanodine receptors is what is on that sarcoplasmic reticulum that gets calcium binds to, right? Calcium gets into the musculoskeletal cells, will go in, bind that ryanodine receptor, and that opens up calcium. If you have an altered ryanodine receptor, that's going to allow all that calcium to flow out of the sarcoplasmic reticulum. You see too much binding of that, too much muscular activation, and you see a lot of heat being produced. You see a lot of acids being produced. That develops a malignant hyperthermia. So if you have a history, that's why I always ask a very thorough history before anyone gets anesthesia. You ask about, does anyone in your family have a history of bad reactions to anesthesia, right? They may not know it was malignant hyperthermia, but they know someone underwent surgery and they had a really bad reaction to the drugs they got. That is usually a pretty clear sign that something's up. There are genetic tests you can do, but because it is so rare, we don't prophylactically test patients for this. It's only if they have a history, a high risk sort of history there. Okay, so again, it's not everyone's going to get it. Very rare that it occurs, but you need to be prepared for it because once it happens, every OR should have a malignant hyperthermia kit ready to go. Where it has like cooled saline, it's going to have sodium bicarb to help fix the acidosis, and what other drug is it going to have? Dantroline's the other one, right? It's a peripheral muscle relaxant. So it's going to have all three of those things in there. Try to cool the patient down, correct the acidosis, and then to try to relax that muscle. ERs will typically have this as well because we use succinylcholine with some regularity. So those are the two places you're going to find malignant hyperthermia carts. Because it is potentially deadly, you need to treat it very rapidly, right? Okay, so again, it's autosomal dominant genetic disorder. So again, ask about family history, if they've ever had a bad reaction to anesthetics before. And again, not commonly we do susceptibility testing. However, it could be used potentially because again, you usually have to do like a muscle biopsy in order to find this. It's the most reliable test, but only used if you have a really high risk patient who really needs a surgery to be done. Okay. And just here's the example of how it's working. The ryanodine receptor there on the sarcoplasmic reticulum. We kind of already talked about this. But the three big things you're going to see is heat, acidosis, and rigidity forming here, right? Okay. Sorry, I'll finish up this section and then I'll let you guys go on a break. But so anyway, typically it's a very rapid onset. So typically the first thing you're actually going to notice is when you're monitoring the temperature for the patient, that'll start to go up. But also if you're monitoring end-tidal CO2, that will also start to go up as well, right? Because you're kind of burning through a lot of that oxygen that the muscular cells have. Once it burns through that, it has to switch over to anaerobic metabolism, and that's when you see a lot of the acidosis start to develop there, right? So again, end-tidal CO2 is going to start to go up. You're going to start to see that muscular rigidity. That's when things are going to start to happen there. You can also see some hyperkalemia because again all the cells are depolarizing, sending out potassium. So if they already had, say renal disorders and they're already hyperkalemic to begin with, that can be worse and cause arrhythmias, etc. But the big treatment here is going to be reducing body temperature, fixing acid-base status, usually sodium bicarb, and then using that dantrolene there, right? What other ways can they use to reduce body temperature? So so cooling blankets. I mentioned cool IV fluids, usually normal saline. Ice packs, you can put them where? Yeah, armpits, groin, those are all good places. You can even do like evaporative cooling, kind of like spritz down the patient, put a fan on them. That will help to cool them down pretty quickly as well. So that's always going to be the case there. Again, rapid recognition is the important thing there. So you can notice it and treat it immediately. So key points here, again, very good from an amnestic sort of standpoint. Very quick offset, which is good. We have to maintain sedation with these drugs, and then when they're done with the procedure, then we want them to be able to recover from it quickly. That's why we use these agents, because they typically have a very fast offset, and they're going to be providing additive sedation to IV drugs. We'll talk about IV drugs when you guys come back. And these are super key to doing that balanced sedation. So again, if you're doing a very light procedure, very like laceration repair, you're probably not going to use these inhaled anesthetics, but generally in the general surgery sort of realm, this is where you're going to use a lot of those, right? Anywho. All right, let's continue. Any questions from the first half? Did you guys all get a breath of fresh air? I've been subtly pumping in halothane to the room because somebody noticed it. Already so sedating as it is. No, I'm just kidding. Anyway, all right, so we're talking about some intravenous agents. So again, these are good for induction of general anesthesia. So we'll give kind of big doses of this kind of up front, get the patient ready for intubation and eventual general anesthesia afterwards. Typically, they can be, in some cases, used as monotherapy by themselves, but in a lot of cases are used as adjuncts, especially in the general surgery sort of realm. These will typically have faster anesthetic action than your inhaled agents, right? So again, by putting it into the bloodstream, it's already kind of solubilizes in the blood, it's ready to go. Versus with the inhaled agents, like it takes some time for it to kind of like fill up the alveolar space to get partitioned over and then partition out into the brain. So quicker onset typically with the IV agents we're going to see here. A lot of them though are going to lack analgesic properties, and so that'll be something you want to know going forward. And we'll talk about the different ones and whether or not they have these analgesia or not. And then the recovery time is going to be highly dependent on the dose of drug we're using and also which type of drug we're going to be using for them, right? So for instance, say something like a long-acting benzodiazepine, it's going to have a lot longer recovery time than you see something like with ketamine. It tends to be a lot shorter. So it all depends on the agent. You'll get a feel for it if you deal with any of these patients in any appreciable means. So the ones we'll cover are going to be the barbiturates. Primary thiopental is one of the big ones we're going to be talking about here. Benzodiazepines, opioids, propofol, etomidate, and ketamine. A lot of these we already covered, so I'm not going to necessarily belabor the points here. We're just going to talk about them really in the context of surgery. So remember the barbiturates, typically they're working how? GABA, they make GABA work better, right? So they're going to be helping GABA to open up those channels, allow for chloride to flow in, hyperpolarize those neurons there, right? The big ones you'll see are things like thiopental. Phenobarb is more predominantly used for what? Yeah, seizures is a big place. We're going to see mostly phenobarbital, but occasionally for surgery purposes, you may see thiopental or pentobarbital. Remember, this is one of those agents they use for lethal injection. Have I mentioned that before? Right, so again, what are the other drugs? Potassium, potassium is usually the thing that actually kills the patient. Usually end up getting another paralytic, so something like, like a rocuronium or something like that. So again, 3 drugs are going to kill them anyway. But again, you use them all in combination, really ensure you do that. But again, you're not going to try to kill your patients, I hope, right? Unless they're very mean to you. You have very bad rooms. Don't do that. Anywho, so typically you may see barbiturates actually being used quite frequently for as a drug of choice for like electroconvulsive therapy. Shocking to hear, I know. Okay, anyway, not done frequently. However, it has been, historically been used as kind of the drug of choice for that. So you may see some barbiturates used in case you have patients who require some electroconvulsive therapy. Anyway, also a very good induction agent. However, no analgesia associated with barbiturates, right? No analgesia whatsoever, and it does tend to decrease blood pressure. So hypotension is going to be a common thing you're going to see with this, cardiac output, and can be useful for increased intracranial pressure. And so I use this, I've seen it used in the trauma realm. You have patients come in with traumatic brain injury, they're worried about herniation or intracranial pressure, they will use barbiturates in order to help kind of bring that down and try to relieve some of that pressure, right? That'd be one beneficial use of using the barbiturates. Anyway, I mentioned thiopental tends to be one of the more commonly used anesthesia induction agents here. And again, it provides pretty rapid loss of consciousness here when you give a big bolus dose IV. But again, just be wary of things like drops in blood pressure. If they're already hypotensive, this is just going to worsen that potentially. And usually what you're going to find, if you can combine with other agents, you'll see kind of synergy there where you can reduce doses of each of the medications. So for instance, if I give this with nitrous oxide, and again, I even made the mistake here. I should say nitrous oxide. See, even I am fallible, quite fallible as it turns out. But nitrous oxide will help to actually reduce that dose somewhat, so you can give less of the thiopental there. And then very potent respiratory depressant, so you need to make sure you're breathing for the patient one way or another, right? And then good for cerebral swelling because it helps to reduce that intracranial pressure pretty significantly. Okay, benzodiazepines. So again, there's a wide variety of benzos, which are kind of go-to IV agents we've kind of talked about before. Lorazepam, diazepam, midazolam. Yeah, those are three of the big IV agents we're going to use most commonly, especially in sort of the surgery sort of realm. So where I see these used most frequently, Ativan or lorazepam, what do we use mostly for? For seizures, right? So you typically see Ativan used mostly for seizures. The reason for that is that even though it's a little bit more water soluble, it takes longer to cross the blood-brain barrier to get in there and prevent seizures. It tends to last a little bit longer, so it's good for helping to prevent kind of recurrent seizures from happening down the line, right? That's why we like Ativan for seizure management. And again, you'll find these things where even though the drugs are really kind of doing the same thing, they all have the same mechanism, you're going to find that you just, in general, you're going to find, okay, we use this one for this, we use this one for this. There may be some reasons behind it. A lot of times there isn't, right? It's just medical dogma you have to kind of work with. Anyway, Versed or midazolam we use very frequently for like kind of the preoperative setting, right? We use it as a very good sort of anxiolytic agent. It's very good for getting someone prepped for surgery, mainly because it's very fat soluble. It's going to be able to cross that blood-brain barrier very quickly, gets in there, and it gets out very quickly as well. So not as great for preventing seizures or for treating seizures. However, it would work just as well. But we'll use this very frequently. I mentioned during the intranasal talk a while ago that intranasal Versed is a very good drug to use if you don't have IV access. So very good from that standpoint. And then diazepam, anyone know what you use that more commonly for? Seizures as well, usually via what route? Yeah, rectal in that case. You can actually use the IV form, use that rectally, or you can use that diastat, which is that rectal gel you can administer. However, I also see very frequently we use this for muscle spasms, right? So I see this a lot like in inpatient rehab units and things like that, where they'll administer diazepam or Valium kind of as needed for muscle spasm. They can help to kind of relax those muscles. But again, all these drugs can work for the same purpose. You'll just find that this is kind of where their niches are kind of lying, where they get used most commonly. Typically, if you're trying to use this for sedation for surgery, not going to be used by themselves. This is really just good as an amnestic sort of agent. They're good for anxiolysis, but they're not going to be good for providing any sort of analgesia. They're not really going to be potent enough to really get your patient down for a good sedation, right? Some people use this as an induction agent for like RSI, but I never like it. I never find my patients really get sedate enough. They usually require kind of repeated doses, and at that point, they're going to be so zonked out that it's impossible to do good neuro exam afterwards. It's just kind of difficult. This is why you like things like etomidate a little bit better because it's a lot more rapid acting in the case for RSI. Anyway, I mentioned these are the three. Midazolam is going to be that benzodiazepine of choice for parenteral administration for surgery purposes because, again, it's going to have very rapid onset because it's so fat soluble, but, again, pretty rapid offset as well. But by the time it wears off, you're giving them something else anyway, right? So you're giving them either some propofol or you're giving them some, inhaled anesthetic or something else along those lines. So, mentioned very good sedative, anxiolytic, but no analgesic properties here, right? Now, how do we reverse the effects of benzodiazepines? Just like we have naloxone for opioids, right, we have flumazenil or romazicon for benzodiazepines. And so this is the only sedative agent we're going to see here that actually has an antagonist, right? So opioids, think naloxone, think benzodiazepines, think romazicon or flumazenil. This is used to potentially shorten the recovery time. So if maybe I only gave them a benzodiazepine, I want to help them wake them up a little bit faster, I can use romazicon. Or if I inadvertently give too much, I iatrogenically cause them to be too sedate, I can give this as well to reverse that. The only thing you want to be careful of is the fact that if they are dependent on benzodiazepines, if they're chronically on benzos, and I reverse this effect, what could I potentially see? Withdrawal, which in this case would be manifesting as seizures, right? So again, benzodiazepine withdrawal can be potentially fatal because it can lead to seizures, right? We don't want to do that. So again, this is not used frequently. However, in the surgery realm, it can help to hasten recovery. So that can be one use. You may see used occasionally. Okay. For the opioid analgesics, these are good, and we'll see pretty high doses of some of these potent opioids being used. Again, usually the fentanyl family is going to be the kind of the more common ones we're going to see used in the surgery realm. We're going to find they tend to, if you use opioids by themselves, there's actually kind of an increased risk for things like, awareness during anesthesia, which again is not what we're shooting for. We like the patient to be completely out. Some post-op recall. Right, so they will have, this is not good as an anesthetic agent by itself. Usually that's why I use in combination with like a benzodiazepine for anesthesia qualities. One of the big things to be careful of, especially when you're using fentanyl, is you want to be careful of giving this too quickly. We can actually see if you give big doses of fentanyl too quickly, that you have chest wall rigidity that develops, and then you can impair oxygenation at that point, right? It becomes very difficult to oxygenate. And how do you think we would fix that? Give them naloxone, right? So you can give them naloxone to reverse that effect. However, what's the downside of doing that? Whatever I was doing to my patient that required them to have opioids, guess what? That analgesia effect is gone now, right? So it's one of the things where you want to try to prevent it whenever possible and kind of slow down your infusion of fentanyl. So it's a big thing we watch out for and not give it too quickly. The other big thing is that typically you're going to find that the more opioids you're going to need for these patients, especially in the post-operative setting, you're going to find more complications. So like from the GI standpoint, what do you expect to see? Constipation, it's going to take them long, the guts are going to be slowing down pretty significantly, see bladder complications, they may require prolonged vent support, things like that. So we like to limit the amount of opioids we need in general. So if we can just give for like some as an induction agent, and then usually in the post-operative setting, they'll have like some PRN, dosing of opioids, right? So for instance, when we have patients who are getting admitted to the inpatient unit after, say, abdominal surgery, say they had appendectomy, they'll come to us. They'll typically have a couple of different orders that are set up, right? So you guys familiar with order sets? What are order sets? Anyone know? Basically, when you go and you say, okay, my patient is coming out from abdominal surgery, you open up a big order set that says general surgery, post-operative orders, and you click off what you want, basically. And so it can include fluids, it can include diet orders, it can include all sorts of things. But basically, what we care about from the pharm standpoint is usually pain medication is the most common thing. So you're going to see usually they'll have some sort of IV opioid that'll be available to them for like severe pain. They'll usually have like an oral option, usually something. What are some good oral opioid options? Like hydrocodone, acetaminophen, oxycodone, acetaminophen, oral morphine's a potential, right? So you may see like they'll have like IV, morphine on board for severe pain. They'll have say Percocet or oxycodone, acetaminophen for moderate pain, and then maybe ibuprofen for light pain. Or minimal pain, things like that. So typically you're going to find there's a combination of drugs that you can use on an as-needed basis, so that way the nurse can administer that if they're having pain. But typically we try to reduce the number of opioids we're having to give these patients, right? So we're always looking for things that are considered to be opioid sparing. That's why we use a lot of like IV Tylenol for these patients, because there's some studies to show, at least in kids, and why we use it so frequently, that it helps to reduce the amount of post-operative opioids they need, and again that gets them to recover faster and gets them out of the hospital faster, right? That means from a hospital standpoint, we get more patients in, make more money. For the patients, it means they get to go home sooner, which is always good, right? So anyway, again, most oftentimes we'll see using those kind of contexts there. They can also be administered via either like subarachnoid or epidural routes for especially like post-op anesthesia. So if you ever see someone who's like coming out of surgery on an epidural, usually it's going to be containing at least one opioid agent, usually a local anesthetic. So usually like fentanyl is the most common one we're going to see used there. So fentanyl and sufentanil tend to require lower doses. They're very potent agents and are typically going to be used as adjuncts to the inhaled anesthetics. There's also remifentanil and alfentanil. And so these have pretty rapid onset of action and can actually work as kind of co-inductive agents. And sometimes we'll use it as kind of continuous infusions to keep the patient very well sedated and have a good amount of analgesia. So I mentioned like the spinal surgeries that tend to be pretty involved. Like they will use like a remifentanil drip along with something like an inhaled anesthetic in order to make sure the patient is completely still, they're not moving at all, and they have good analgesia on board. Because again, that can be very painful if the patient had any kind of recollection of that. Other ones you may see being used, things like morphine, again, not good for like induction purposes because we typically want something very short acting. And so the fentanyl agents are very short acting from that standpoint and are better for surgery purposes. But when the patient gets out of surgery, morphine's a good agent, either IV or oral. They can use that pretty frequently. And then we mentioned, fentanyl, sufentanil, remifentanil, and alfentanil. So kind of fentanyl in the fentanyl family is my dad always talked about. Mainly used in the surgical setting, right? Typically a lot shorter acting. I can control and dial in that dose a lot better. Also mentioned from an intranasal standpoint, we can use fentanyl if you don't have IV access, which is good like in, in the ER setting. If you need to do something like a laceration repair or something, you need a little bit of analgesia, intranasal fentanyl is a great option there. Okay. And remember the antidote for opioids is? Naloxone or Narcan. Remember Narcan does not act super long, only about 20-30 minutes or so. So you may need repeated doses depending on how long the drug's sticking around. But usually for like recovery after surgery, they don't require a ton because again, the patient's usually has had something painful done to them, so typically you don't want to reverse that necessarily. So anyway, next up we have propofol. Remember any issues with propofol? Hypotension is a big one, so you can certainly see that. Anything else? Respiratory depression can certainly cause that. And opioids can do that too, right? Remember that. That's one of the big side effects you see with that. Anything else? Any allergies to worry about with propofol? Egg or soy allergies, right? Remember, because it has to go into solution in that lipid emulsion, so you have to make sure you have check for allergies first. Any egg or soy allergy that are legitimate, you want to go ahead and avoid propofol for these patients. But again, very similar actions to the IV barbiturates, and so we've actually kind of been using propofol a lot more frequently. We use this a lot for like adults for like procedural sedation. So say they have like a dislocated shoulder, you need to reduce. Like we can use propofol a lot in these cases. Again, for adults, we typically avoid ketamine if we can. We'll talk about that in a second, but propofol is great for like adult sort of short procedures because again, it's a pretty short duration of action for them. Again, working through as a GABA A receptor agonist, going to be directly opening up those GABA channels there. Good for IV sedation, good for prolonged sedation for ICU patients. So again, you can use that for helping to keep a patient synchronous on the vent, keep them nice and sedate. Propofol uses it very frequently for that. Keep in mind the longer you have patients on this from a continuous infusion, you may find that the levels will build up over time, and it'll take time for that to kind of wear off. So you may have a little bit longer recovery time for that for these ICU patients are on for days to weeks, right? The other big thing, because it's in a lipid emulsion, if they're getting it for a long period of time, you have to look at their triglycerides because those will increase. However, it's not really a big deal for just kind of an acute surgery sort of thing here. And then also in those ICU patients who are getting high doses for a long period of time, they can develop this PRIS syndrome, which is basically propofol-related infusion syndrome, where they get metabolic acidosis related to that. And so you might find that you have to switch them over to something else. It's not going to cause that. So again, just a few things to worry about. And again, was it turn your urine? What color? Green, right? So kind of unique from that standpoint. So anyway, very short duration of action, which is why it's good for like ambulatory surgery, things you don't need patients to be sedate for a very long time for. But just remember, hypotension, respiratory depression, you may find some pain in the injection site, but again, that's pretty mild. Not going to be a big deal, especially because they're pretty sedated after getting the propofol anyway. Okay, etomidate. Where do we use etomidate for? RSI, yeah. You could use this as an induction agent in general. I don't see it used a lot in those situations. However, certainly for RSI, I see this used most common. It's probably the #1 place where I see etomidate being used. Remember any issues with etomidate? Yeah, so you may see like trismus, you may see some myoclonus associated. That is a certain concern, which can be ameliorated by giving something like a paralytic, certainly. Anything else? Yeah, so it can cause adrenal suppression, right? So that can be another big issue of like a septic patient or something like that. You may have issues with blood pressure management, but certainly that is a concern you need to be watchful for. So again, not used frequently outside of that, but you may see it used in some surgical situations. But again, I'm not going to belabor the points here. We've kind of covered a lot of these already, so I'm just going to kind of hit on it from a surgical context. But that's mainly what we're going to see is get a patient ready for intubation. The nice thing here, though, it doesn't really hit the blood pressure, doesn't really hit respiratory rate as much as you're going to see with like propofol or something. So if you needed to, you know, say for instance, try to intubate a patient but did not go well, you don't have to worry about the respiratory drive taking as big of a hit as they would on something like propofol. So anyway, very fast acting. Again, remember that myoclonic activity. That's kind of the big things you expect to worry about, especially if you know, especially that trismus that can occur there can make it very difficult to intubate the patient. Again, that can be overcome though with the paralytic. Okay. Ketamine. So who is ketamine not good for? Adults, right? Why not adults? Yeah, dysphoric reactions, right? So again, I always equate it back to the way I make sense in my mind is like I think little kids, they don't have a whole lot of psychological baggage quite yet, right? We haven't really not been subjected to the world. Some of them have seen some stuff, right? But with adults, though, they've usually got some issues, right? And so again, with the dissociative anesthetic, they tend not to have as good of a time. They tend to have more of this dysphoria when they're coming out of it. So that's why I don't like ketamine, and a lot of people don't like ketamine for adult patients. In some cases, you might see something called ketofol being used. Anyone know what that is? Can they intuit what that is? Yeah, it's actually ketamine and propofol. You actually put it in the same syringe. So sometimes we'll use that. That can be used for adult patients occasionally. But the nice thing, though, is because if you think blood pressure being an issue with propofol, what does ketamine do to blood pressure? Actually increases, right? So you can actually see some balanced effects there if you mix ketamine and propofol together. But you're going to find that this is a good drug, especially for kids. Really no hit on the respiratory drive, so it's great from that standpoint. Very fast acting for the most part. This is unique because it actually provides analgesia and sedation, right? So again, a lot of these other agents, the barbs, propofol, not really causing as much analgesia, but this one definitely has provides kind of a dual role there. So you really only have to give this drug and kind of act all by itself for the most part. What other patients would I want to avoid this in? So if they're already hypertensive, I probably wouldn't want to give it. Well, I mentioned adults who might have a dysphoric reaction. Yeah, intracranial pressure, right? So they have an increased intracranial pressure, and again, that's more of a theoretical concern, but it's still a concern. You want to, probably want to avoid that for patients who have cerebral edema or a head injury, anything like that. You probably want to avoid that. Anyone else you can think of? Those are the big ones. This is also really good for asthmatic patients because remember, it's also a bronchodilator, so that can be very handy from that standpoint. And actually, I just saw something the other day. There's starting to be a lot more trials being done with ketamine for use for things like treatment-resistant depression, for like PTSD. They're finding like even after a single dose of like pretty low dose ketamine, finding pretty good effects on patients' depression. So this may be something you see years down the road. This is maybe standard of care for some patients. So who knows? One of the problems you find with like doing clinical studies with illicit substances, especially like Schedule I substances, it's very difficult to get a hold of the materials, right? So for instance, like doing studies with marijuana, very difficult because federally it's still Schedule I, right? Doing studies with things like psilocybin, which anyone know where you find psilocybin?
Mushroom?
Yeah, magic mushrooms basically, right? Good to know you jumped in with that answer. Just kidding. No, yeah, so magic mushrooms, like that's another thing that has similar effects to ketamine. However, studies with ketamine are much easier because that's a C3, right? So I can get a hold of that from a research standpoint much easier than I could a Schedule I substance. So again, you may find things change down the road, but ketamine is one of those things you may see used for depression, right? PTSD, things like that in the future, which can be great because again, some depression is very hard to treat, so this would be another option. Anywho, so again, great agent from an anesthetic and analgesic sort of standpoint here, but again, remember the ICP issues, remember that post-op psychic phenomenon, that dysphoria patients can experience. So again, if they were developing that, they started getting agitated and kind of delirious, how'd you treat that? Probably not Halothane, probably give something, but along those same lines, something, a sedative agent. But yeah, usually benzo, right? Benzo, you can't really go wrong with that. However, if I use ketamine because they're going to have a quick recovery, now I'm giving a benzo on top of that, guess what? I'm starting to extend out that recovery time. It's going to be much more difficult to get that patient out. So like for instance, like we had one, usually like with ketamine, if we have to like reduce a fracture for a kid, usually they get it, usually in 20-30 minutes or so, they're starting to wake back up, and then within another hour, you know, they're tolerating PO fluids and they're usually good to go home. But you know, we had one teenager who's coming in, had a very bad dysphoric reaction. They're coming out, ended up getting like two doses of Ativan afterwards, just to treat that. And I mean, it was hours, you know, before that patient can actually get out of the the ER. So again, turnover time is a really important thing to consider. And by having to give all those extra doses, you kind of lost the effect of using ketamine in the first place. You know, the benefits there. So, and it's hard to predict who's going to have a bad reaction. It's just one of those things you can't really tell. The other big thing is a lot of nausea and vomiting associated with this, and make sure consider pre-treating with Zofran. Okay, so again, you can go through and kind of compare these, but we've kind of covered the main points here. All of these are perfectly valid agents for kind of induction of anesthesia, all save for the Versed. This is going to be much better for just kind of like pre-op anxiolysis, kind of chill your patient out before getting some of these more kind of heavy-duty agents. Okay, so we mentioned conscious sedation. Anyone know what that means? I say conscious sedation. Yeah, it's more like a moderate sedation where a patient is still going to be breathing on their own typically. You may find that the patient is still having, I go back to ketamine. Ketamine is the one we do conscious sedation on most frequently. This is not something like you're doing like in kind of like abdominal surgery. This is like very light stuff like, you know, reducing fractures, dislocated shoulders, things like that. We're doing this conscious sedation where the patient is still, you know, in some cases may be able to respond to verbal stimuli. They may still seem like they have some sensation, but we're giving them things that kind of allow us to get in, do our procedure, and then get out, and the patient can recover more quickly. So I mentioned with like ketamine, I mentioned it's a dissociative sort of anesthetic. So when I give ketamine to, say, a child, not recreationally, in a hospital, typically I'll say, you know, or we'll say, you know, what do you like to do the best? And they'll say, oh, I like to play baseball. Okay, well, dream about playing baseball. And then when they go under, they have a very good dream where they were playing baseball with, I don't know, Babe Ruth. Is that what the kids are into? I don't know sports very good. Anyway. So anyway, when the kid comes out, they have a very good reaction, and then they're good to go. We will monitor them from a respiratory standpoint, particularly their respiratory drive never takes a hit, blood pressure is good. We're monitoring for everything just in case something bad happens, but most of the time they recover very quickly. Similarly, like for propofol, we're giving them moderate doses to try to get a decent amount of sedation where we can do our procedure, and then they recover very quickly. So this is what we call conscious sedation, where hopefully they're maintaining a patent airway. They can still be somewhat responsive, and like we have to like tell parents and stuff when their kids get ketamine that listen, like they still may make sounds, they may act like they're in pain, but their brain's just not there. They're completely dissociated. They're off, you know, doing whatever they're doing, right? So again, they're not here for that procedure. Because again, if the patient all of a sudden screams out, which can occur occasionally, the parents think, oh, my kid needs more drug, and really they probably don't in a lot of the cases there. But you know, things like ketamine are great for this. Propofol, Versed, Valium can all be good agents for these kind of conscious sedations where basically we're not having to intubate the patient, we're not breathing for them. You're prepared for that, right? You have things like oral airways that are available and whatnot, but you're not, the patient is still kind of with it enough to protect their airway. That's the big thing there. Other concerns here, you know, using benzos and using things like opioids are nice because they also have reversal agents. So potentially, if a patient got too sedated, they went from more of a moderate sedation to more of a deep sedation, I can reverse that pretty quickly. Can't really do that with ketamine, can't really do that with propofol. You just kind of have to give them time to process the drug out of their system. But that could be one advantage using a benzo or opioid. Sometimes we'll do this, like especially like in the ICU setting. So especially if you need to do something like bronchoscopy or something like that, patients may need some additional sedation to try to allow you to do a procedure. And oftentimes these patients are also on mechanical ventilation anyway, so you may be giving them some additional drugs in order to make sure they're extra sedate. So use combination meds. We'll talk about, you know, sedative hypnotics like benzodiazepines, barbs occasionally. Sometimes we'll use neuromuscular blockers. So again, that goes back to our paralytics. Usually, what agents are we referring to? Things like rocuronium, vecuronium. We'll use those more frequently for like a conscious sedation like this, especially if they're already intubated. Sux is really only used for like a rapid sequence sort of intubation setting here. And also we use a drug called dexmedetomidine. Anyone ever heard of this drug before? A drug called Precedex. This is kind of a newer drug we'll talk about here. So Precedex is actually an alpha-2 agonist. You guys remember any drugs that did alpha-2 agonism? Clonidine, I have a great memory, guys. Yeah, clonidine was a drug we used there, and basically this is in the same family as clonidine. It's just an IV, very potent agent. And so what's nice is by activating the alpha-2 receptors, what does that do for us? Remember it's a, yeah, it's called vasodilation. Yeah, so it's a sympatholytic, right? So we're decreasing the sympathetic nervous system. What do you think that does to your level of consciousness? Typically sedate, yeah. So you think about someone who's on clonidine, maybe they got too much clonidine, they're typically are pretty sedate. Same thing's happening here. And certainly we see some cardiovascular effects. We can see some bradycardia, hypotension. Generally it's pretty light though. And again, this is a very quick acting agent. So I can give them a dose of Precedex, kind of chill them out. This is really good for, and we're starting to use this occasionally for things like, for MRIs, right? Usually if an MRI takes, depending on the type of imaging you're doing, it's taking a while, right? They have to stay still for that entire time. How likely is it you're going to keep a kid still for like an hour? Impossible, right? So they're going to move, but by giving them a sedative agent, a nice light sedative, something like Precedex, you can keep them chilled out, keep them nice and calm. Similarly, if they were agitated, get some anxiolysis out of this, so there's some benefits using Precedex. And it's also good for kind of keeping patients kind of lightly sedated. You can use it sometimes as a continuous infusion. Not nearly as good a sedative as something like fentanyl or something like a benzo. But if you don't need light sedation, this is a great drug for that. Someone said that I might try to sedate like my 90-year-old grandma with this stuff, but otherwise it's going to be pretty wimpy. So I kind of think about this as kind of being light on the sedation scale, if anything. But the higher doses you run, big boluses, hypotension, bradycardia are certainly some concerns you're going to run into with that. Okay, and then kind of going from there into the deep sedation is we're going to run into decreased consciousness. Typically, the patient's not going to be easily aroused, even though like painful stimuli, so you can do external rubs and they're just not really respond to you. Typically, if you're like in the ER doing like conscious sedation, you don't want them to get to this point. It's always a risk and it's always a concern you're monitoring for. But typically, at this point, they're going to be losing that ability to maintain their airway and probably not going to be very verbally responsive, right? And depending on the situation, maybe kind of indistinguishable for like an IV anesthesia you would get with something like remifentanil or something like that. Typically, when you're moving on to things like higher dose propofol, bigger dose opioids like fentanyl, ketamine, you can move into this kind of deeper sedation realm. And this can be perfect for depending on what you're trying to sedate the patient for. But in some cases, you may need something lighter, you may need something deeper. It all just depends on the procedure. So again, the choice of anesthetic is going to depend on the type of surgery you're doing. So again, the location can really dictate what kind of anesthetic you're going to be using here. Anticipated length of the procedure can be important here as well. In some cases, for instance, we'll do like some day surgery stuff over at Nemours where we're doing intrathecal injection of medications for some patients, usually like chemotherapy drugs. And so like you're only doing a lumbar puncture basically, injecting the drug, and then you're done basically. So I don't need something long acting. Give a single dose of propofol, and they're generally good to go. So again, depends on surgery, depends on length, procedure, and then like the patient conditions are important as well. So what are their comorbidities? What's their age? Previous experiences with anesthesia, especially family history, can be important to clue you in if there's any risk for malignant hyperthermia. Obviously, think about available equipment. You always want to have your intubation equipment at the bedside ready to go just in case. You always want to have things like oral airways and things like that just in case. Hopefully you don't need them, but you may need them. And then it also depends on the preference of the anesthesiologist and the patient. Some people are like, hey, I just don't really respond well to ketamine. I've gotten ketamine before. I had a really bad reaction. Well, don't use ketamine for that patient again. Or the anesthesiologist may really prefer, hey, I want you to use this drug, and that's what they prefer. And that's just their preference. But it's good to know, hey, what are they getting? What have they gotten in the past? That helps to inform what you can use going forward. Okay, let's see. So I'm going to go ahead and let you guys go now. We're going to finish up these last section on, Thursday? Yeah, and then we'll do the review afterwards. So I might have to truncate the review a little bit, but that way we can finish material, do the review, and then we'll be done with farm. Bittersweet, I would say. Hopefully. Maybe not just sweet. Although there are ants around here, so maybe that's what was causing it. Anyway. All right, so any questions before I let you guys go? Nope. All right, well, I'll see you actually tomorrow, but I'll see you later.